Hey, good optometry day, everyone. And I am so excited for this next topic. My name is Michael Nelson. I'm your moderator for this session. And this topic is going to be evidence-based basis for myopia management. And I'm an optometrist here in Canada. And this morning I'm seeing patients in my clinic, and I had 6 patients this morning that I was dealing with myopia management. So I'm excited about this lecture. Our speaker today is Dr. Nicola Logan. And Dr. Logan, she is a professor of optometry and physiological optics at the School of Optometry in Aston University, Birmingham, in the UK. Dr. Logan's research interests are with the epidemiology of refractive error and the development and etiology of myopia and myopia control. And I am so excited to hear everything she has to say. So welcome, Dr. Logan, and take it away.
Thank you very much, Michael, for that introduction. I'm really excited to be with you this evening today, whatever time it is, in whatever part of the world that you're in. I'm just going to share some slides with you. Okay, perfect. That's come up for you all now. So as Michael said, I'm based at Aston University, Birmingham, in the UK. And I have a real passion for myopia, a real interest. And I've been working in the field of myopia now for over 20 years. I'm really interested in why children develop myopia. What are the mechanisms really behind it occurring? And then once it does occur, why does it keep progressing? Why does it keep getting worse each time that you see that child in your clinical practice? I'm really interested in ways that we can perhaps mitigate that. We can reduce that risk of them developing myopia in the first place. But if they do develop myopia, what kind of strategies, what can we do in our clinical practice to try and slow down that progression of myopia in children? So as well as looking kind of at mechanisms in the research lab, I run a research clinic where we have a number of clinical trials across a range of different interventions, really aimed to slow down progression of myopia in children. And alongside that, I run kind of a general myopia clinic, and that's really for children who don't want to take part in a clinical trial or study, or who perhaps don't fit the parameters or don't want to commit to that. So we offer options for them as well. And so I'm also an optometrist working in a myopia clinic. But as a researcher, I spend my days looking at new publications on different strategies for myopia management. And there's a whole wealth of information that's been published recently, especially over those last few years. And I think if you've attended any conference over the last few years, you will also have seen that there are more and more presentations on myopia management. But as an optometrist or eye care practitioner, how can you keep up to date with all that information? How can you assess kind of that quality of that information that you're seeing? And if a new strategy or intervention does come to market, how do you know if it's worth including in your tools available for myopia management? So today I'm just going to talk you through some pointers really to consider when you're viewing that evidence base, and kind of relate it to different examples for myopia management. So let's start with evidence-based medicine. And that term's really been around since the 1990s, and it was really introduced to help medical students assess, make their clinical decisions based on the best evidence to date. And so it's a movement really that aims to increase the use of high quality clinical research in our clinical decision making. And evidence-based medicine really requires some new skills of that clinician, things like including efficient literature searching for relevant information, and then applying kind of formal rules of evidence in terms of how you evaluate that clinical literature. And that whole practice of evidence-based medicine is really a process of lifelong and self-directed or problem-based learning, in which caring, for our own patients really creates a need for clinically important information about the diagnosis, prognosis, therapy, and other clinical healthcare issues. So by taking this kind of evidence-based medicine approach, hopefully we can then improve, that healthcare for our own patients. And if we look at evidence-based practice, and I think that's what most of us try to do in our own clinical optometry practice. And that evidence-based practice is really developed from evidence-based medicine, and its principles really center on kind of the application of clinical research to patient care. And it supports kind of the healthcare decisions that we make using that kind of strongest available research evidence from our scientific peer-reviewed journals. And we need to also use our own kind of a clinical judgment alongside also kind of the preferences or requirements of our own individual patient. And kind of adhering to that, if we look at kind of our clinical experience, look at the best available research evidence to date, and consider our kind of patient values or requirements, then we're working under evidence-based practice really to improve the health or eye care for our individual patients. But where do we look to get that information? Well, there's a lot of information produced by companies that produce new interventions for myopia management, and they have a lot of supporting evidence alongside that. Of course, there are published articles in peer-reviewed journals. But as an optometrist in practice, do you always have access to those? Can you get to that full article because they're often behind a paywall? But we can go to a conference. We can be exposed to that kind of latest research at conferences, but that requires us to attend on quite a regular basis. What about those articles that are published in a trade magazine, for example? Are they an opinion piece or someone's preferences, or are they truly kind of based on that kind of peer-reviewed publication data? We might talk to our fellow eye care practitioners. We get a wealth of information and support from fellow eye care practitioners. So should we listen to them in terms of what they're saying about different interventions? But I guess you might query where their source of information came from. And is it that kind of latest evidence-based source? And we can turn to social media. We can, see Facebook groups, for example, that have a huge following. And again, there's lots of opinion that's discussed in that type of forum as well. And so a variety of different aspects where we might get information from, and it's kind of weighing up, that quality of the information from those different sources. And if we look at kind of a hierarchy to our research evidence. So there is a clear hierarchy of research evidence. And this hierarchical evidence model that you can see in the slide here really kind of categorizes the strength of evidence from different academic sources. And they range from systematic reviews and meta-analysis of randomized controlled trials right at the very top of the pyramid. And those systematic reviews and meta-analysis are comparing the results from lots of different studies and putting them together. So it's not a new study, it's looking across at studies that have already been published. And we run down then through randomized controlled trials to things like case reports, to expert opinion communications. And this can really help eye care practitioners kind of appraise that strength of the evidence presented. But we know that these types of models have been challenged as elements such as patient selection can make a more robust research design less clinically applicable a particular condition, for example. So if we start right down at the bottom of the pyramid, we have, it's wider across the bottom because it's representing a huge wealth of information. And that's things like expert opinion and editorials. But the quality of it might be a little bit variable. And if we move up through this pyramid, then we've kind of, as we narrow down those bands, we can think of that kind of strength of the evidence increasing as we move towards the top of the pyramid. And we saw our case report is going to be a better design in terms of expert opinion, but they still have lots of issues or problems related to them. And essentially right at the top of kind of studies, we have our randomized controlled trials. And that's currently where we sit as the kind of what the gold standard is in terms of quality. So a randomized controlled trial will be a very well-designed study that gives us great data to a very specific research question. And as I said, right at the top is that systematic review, meta-analysis that's looking at data already published and kind of assimilating differences from those different studies. So in terms of our best evidence for a new study or a new trial that's coming out, we're looking at a randomized controlled trial. And what kind of aspects should you be kind of looking at? We're looking at study design. So whether it's a randomized controlled trial, whether it's a case report series, for example. And within that, we're looking at that kind of number of cases presented or analyzed. We also want to kind of look at patient selection. What type of participants have been included in this study. And we also want to see if there's been some sort of implementation in the study to minimize bias. We want to pay attention to the length of the study because that will influence outcomes. And we know certainly from myopia management studies that we see often great effect in year 1 and less effect in year 2. So if you're just reporting data from year 1, you might have an inflation in terms of study outcomes. What variables have they measured? Things like the primary outcomes might be refractive error and axial length in a myopia study, for example, but you might also want to see any impact on things like visual acuity or contrast sensitivity, for example. And also, if there's safety concerns, how are they monitoring that? Have they measured things that allow you to say whether the intervention is safe? In terms of statistical analysis, this will be taken into account really in terms of the peer review process should really assess that. But we need to be careful when we're talking about eyes because an individual typically has 2 eyes and we know we have a really tight correlation between our right and left eyes. So if we measure refractive error in the right eye, it's pretty much going to be very, very similar in the left eye. So we can't just double up number of eyes in our sample size because that will introduce bias as well. And if they've done that, has there been some sort of modification done to the stats to allow for that type of model? And is there an effect replication? And what I mean by that is that perhaps has a study been done in a different population, in a different location, for example? It's not just a one-off study in one place. So in terms of evaluating study design, we can think of our study design in a little bit more detail. So first of all, we consider if it's a prospective or retrospective study where you might want to look and see if there's a control group that runs alongside an intervention group, what the study participants have been, where the study has been conducted, the age range of those participants. Is it a group that aligns with the children that you see in your clinical practice? So if you've got children who are normally between 8 and 12 years of age, who are typically presenting with myopia, has this intervention been done in a similar age range? Has it been done in young adults, for example? Are you likely to have a comparative effect in a different type of age range than what you see in your clinical practice? Has the study been randomized with a control arm? Masking is important so we don't have bias. The length of the study we want to know how many years it's been running for. And importantly, we want to know what those outcome measures are in terms of reporting study findings. So let's just delve a little bit deeper into each of those parameters. So let's look first of all at study design. And is it a prospective versus retrospective study? So here, prospective study, we're following subjects, we're putting participants into a new study, and then we're following through over time to see what happens to them. So we have no idea what the outcomes will be at the start of the study. A retrospective study is where we are then have children, they've had some sort of intervention, we know what their status is, but we perhaps look backwards at their kind of chart or clinic records to see what's happened previously. And that's a retrospective study. And both are valid ways of looking at data, but a retrospective study might introduce some greater bias in terms of study results because we already know the final outcome. In terms of a control group, it's really important that you're looking at, if you're looking at studies that you're reading about, to see if control group has been used or not. And if there's no control group used within a study, then we're not able to report the efficacy of that intervention, for example, because we've got nothing to compare it against. And the importance of that control group that runs alongside our intervention or treatment group is that we can see what differences are happening in those two groups concurrently. And if we have no control group, then we might be looking at what's happened previously to those children or to other children in another study and using a historical control group. And this might introduce some aspects of bias in terms of recall as to what's happened or selection bias as to who we include as a control group. And this kind of introduced some confounders in to our study if we're using the historical control group. And in terms of where we are for an ideal kind of a study is that we have a placebo or a masked control group, and that's really considered our kind of gold standard for long-term myopia control studies. And this is really what's often required for regulatory purposes. When a company wants to take something to market, they need to know what's happened with a masked, a placebo control group. And those children really need to be matched for both age, but also the level of refractive error. So we can't have, lots of children with just -1 diopter in an intervention group and lots of children with -5 diopters in a control group. They need to be matched equally, similarly for their age. But we could also consider matching a little bit more critically in terms of considering other factors that might influence myopia progression or growth rate by looking at time outdoors, parental myopia status, or ethnicity, for example. And if we do have a study design that has a control group and an intervention group, then those children should be randomized to those two groups. We don't want to kind of self-select who's going to be in the intervention group and then put the others into the control group. And that kind of randomization should be determined by chance alone. And that means if we look at those kind of baseline measures between those two groups, they should be evenly matched in terms of kind of age, refractive error, etc., if we have done that randomization process. So it's really important to consider whether a study is masked or not, because this is where we often could introduce bias into a study. And it could be an open label design where the parents, the children, the investigators know which study group they're in, but we know that this can also introduce some bias in terms of subjective bias in terms of how we take those measurements, for example. An open label type of study could also introduce some effect in terms of compliance with the intervention. So if they know they're in a treatment group, for example, they might be more likely to comply. If they know they're in the control group, they might be less likely to comply. And our gold standard really is a double masked study. And this really eliminates the subjective bias. And a double masked study is where the investigators and the participants, or neither the participants or the investigators, know which group that they're in. But we know that sometimes it's not always possible to mask participants. If we think of an ortho K study, for example, children will be wearing ortho K, will clearly know that they're wearing a lens to sleep in at nighttime. And the control group's usually a spectacle lens wearing group, and they know they're wearing spectacle lenses. But what we can do in that type of design is then mask the investigators. So when they come in, it's different people who take those study outcome measures, and they don't know who's in the ortho K group versus the spectacle group. So read those kind of papers carefully and kind of look at that level of masking that's within that study design. It's also really important to consider, the length of the study. Has it been done over a 1-year period or a longer term over multiple years, for example? So a 1-year study will give us results over a shorter time frame, because often we're looking for a new intervention. We want to know if it works. How quickly can we get those results in? So 1 year will give us lots of data in a short time. But we know there might be some bias in that. We often know that we get really effective results over that first year that don't then necessarily follow through years 2 and 3 in the same level. And we also know that kind of myopia progression isn't necessarily linear in nature. How myopia progresses in 1 year doesn't always necessarily follow through to the next year. So there's a real need to run that run the study over a longer time period. If we run for years and years and years, then we really have a great understanding of how an intervention is working. But is it ethically to do so if you've got children in a control arm to run for lots and lots of years? So we're looking for that kind of balance. Where do we get that trade-off where we have a huge wealth of information, but we're not then disadvantaging those children who are in the control arm? It's also really hugely costly to keep a clinical trial running for a large number of years. And there seems to be consensus really from the International Myopia Institute that 3 years is often kind of the recommended length for a clinical trial when we're trying to assess the efficacy of myopia control for regulatory purposes. So other points to consider really with that kind of variation of myopia is that age of onset, so early versus late in terms of how fast we're going to see progression. We get variations in rate of progression and duration of progression. And really to capture all that variability, we're kind of looking for a 3-year study design. For studies that are looking at kind of efficacy for myopia control intervention, there's often 2 primary outcome measures, both axial length and refractive error. Because with any sort of myopia management intervention, we're looking to slow down both the rate of axial eye growth alongside that rate of myopia progression. And for refractive error, it's really recommended to measure it under cycloplegic conditions. And again, from the International Myopia Institute, the consensus is 2 drops of 1% tropicamide separated by 5 minutes should give us enough depth of cycloplegia. But certainly, I appreciate that for many optometrists working in practice, refractive error is what we're using to assess whether myopia is progressing or not, because that's the measure we talk to in terms of our patients and their parents. And it's a measure that we change their optical appliance with as well, based on a refractive error change alongside the VA. But ultimately, what we're trying to do with any myopia management intervention is slow that rate of axial elongation. And that's why it's really important that we have both those measures reported in any intervention. Other points that we might want to consider are the age range of participants. So we know myopia typically develops, very slightly in different parts of the world, but on average, kind of 7 to 12 years of age. And that's where we typically get that fastest progression. So that's kind of the age range that we're looking to see that the studies have been done on. We also want to know, if we're reading a research paper, are the demographics of the study subjects relevant to our own clinical practice? So has that study been done in the country that you reside in, that you work in, or in one that's reflective or representative of that? Has there been many dropouts in this study? Because that would either indicate that the intervention that the children are having difficulty complying with the intervention, or there's some sort of issue with it. And that can then introduce bias if you have lots of children in an intervention group dropping out, for example. We then won't have nicely matched groups between an intervention and control. And it's really important any intervention study measures compliance to the best of their ability, because we want to know that wearing times. If it's an optical intervention, the child needs to be wearing it during waking hours, for example. How can we monitor that? Is that reported in that study that you're reading about? And I think if, like me, you probably got amassed a pile of papers that you want to read and just struggling to find time to delve into them a little bit more deeply. It's often time pressures, not because you don't want to, not because they don't seem exciting or new, but just trying to fit that into a busy working day can be quite challenging. So if you don't have time to delve deeply into it, or if you don't have full access to that paper because it's behind a paywall, for example, can you get enough information just from reading an abstract to give you a sense of whether you want to read that paper more fully or get access to it? And I just want to use 3 papers today to kind of talk through those different kind of scenarios in terms of what information I can get just from that abstract. They're all related to myopia management. They all relate to soft daily disposable contact lenses. They all have different designs to try and slow myopia progression in children. One is a disc lens, the other is an extended depth of focus lens, and the third one is a dual focus contact lens. So let's have a little look at those in a little bit more detail. So this is just part of the abstract, not even the full abstract, from the disc paper, and the disc stands for Defocus Incorporated Soft Contact Lenses. It was a study done in Hong Kong using soft daily disposable contact lenses to see if it could slow down progression of myopia in children. Have a little look at the abstract here. See if you can tease out some of those points that you consider to be important based on what I've just said within today's presentation. So just have a little look at that abstract. Think what jumps out at you based on what I've said. What information is there? I'm just going to highlight those, and I hope that these are the ones that jumped out at you. So it's a 2-year study. That's good. It's longer than 1 year. So we have some longer term data, but it's 2 years. It's a double-blind randomized controlled trial. So that's great. That's kind of our gold standard in terms of a randomized controlled trial. It's double blind, it's masked really well, so neither the investigators or the participants knew which treatment arm they were in. I've just pulled out the number of children here. 221 children in this study, so a large number of children here. 8 to 13 years of age, and that corresponds to what we talked about earlier, where we see that kind of myopia development and faster level of progression. And the study used 2 primary outcome measures. You can see I've highlighted here refractive error, and that was measured under cycloplegic autorefraction conditions, which are typically standard for a clinical study. And they've also measured axial length. So we can see here, without even delving deeper into this paper, and without even having a look at the results, we can see that it's a well-designed study. It's got the key points included here. It's on the right age range, and it's got our 2 primary outcome measures that we are interested in. Let's have a look at the second paper, and it's an extended depth of focus lens, the natural lens from VTI. Have a look here at the key points. What jumps out at you from this abstract? I've highlighted some points here. It's a little bit different. So it's looking at the rate of myopia progression in children. What I've highlighted, it's a retrospective study. So it already knows the outcomes, and it's looking backwards through the record charts to see what happened previously for these children. We've got 32 participants, so a big difference in numbers between this and the previous study. But have a little look at the age range. That's where we're also seeing difference. It's wider at 6 to 19 years of age. And yes, we can still see myopia progressing, through those later teenage years. So it is important for us to have information on that. But are 32 over that really wide age range enough to give us a full sense of what's happening here? I've also teased out some other words here. So they incorporated participants that had previous use of myopia control strategies. And some of them were wearing soft multifocal contact lenses or orthokeratology lenses prior to using the extended depth of focus lenses. And that study duration is also quite wide. The follow-up time was 6 months up to 25 months. And as I said, right up at the top of the abstract here, you can see the primary outcome measure in this study was just looking at refractive error, that change in myopia progression. So you can see already from just really the methods section alone from those abstracts that we're starting to see some differences between study designs. Third one I just want to highlight is on a dual focus contact lens, and it's the MySight One Day lens by Cooper Vision. And I should declare some interest here because I was one of the investigators on this study. So what do we know about this? So again, from just looking at the abstract, if we pull out the key points, it's a randomized clinical study. It's double masked. So again, the investigators or participants didn't know who was in which group. If we look at our age range, it's children aged 8 to 12 years of age. And that study duration is for 3 years. You can also see that the report control group was used within it and detail what was used for the control arm. And it had the 2 primary outcome measures, the spherical equivalent refraction data measured under cycloplegia and axial length. So let's have a little look at those 3 interventions here and some of those differences. And in the first column, we can see the the parameters or the points that you want to consider or look for within the study. So in terms of design, masking, randomization, whether a control group is used, the study duration, age of participants, study subjects, and primary outcome variables. And quite clearly, through these three different options here, we've got some variability within them. But this type of thing, just teasing it out from the abstract, will give you a really good sense of study design and how well the study was done, and then before you even look at the results to determine whether you want to try and implement those in your own clinical practice. So what are we looking for in an optimum study design? So just recap some of those points. If we're looking at a new intervention, I think it's really important that we compare that to a placebo or control group. And if it's not being compared to a control group, then to another existing intervention. We're getting to that stage now where we're starting to question whether it's ethically we want to put children into a control group or not, knowing as we do now that we do have interventions that can or do seem to slow down myopia progression and rate of axial length growth. So either a comparison to a placebo control or another existing intervention where there is a lot of published information from. I think it's really paramount that we have both refractive error data and axial elongation data. And that's for any clinical study, because ultimately we know all the consequences of having myopia all relate to that longer eye, that kind of stretched eye leading to the greater risk of ocular pathology, disease in later life. And that's why it's important we want an intervention to act on slowing axial elongation as well. We know that a one-year study might not be long enough to give us kind of long-term outcomes. Think about myopia progression in children. It doesn't happen over a one-year time span or even a 2 or 3 year. It's there for a longer time period. And that's why we want that kind of longer study duration. So we know from the International Myopia Institute that 3 years seems to be suggested as a suitable timeline. We know that longer than that is not necessarily ethical for children to be in a placebo for that longer term. In terms of study group or study numbers, then we know if it's a new intervention, there's always risks alongside it. So a small study number will expose fewer patients to any side effects. But on the other hand, we know that a large group will give us more reliable results, but it takes longer to recruit and longer to manage. So it's a trade-off between those two. And any well-designed study will typically work out a sample size calculation and report that within the study itself. So there are a range of optical interventions. So I just kind of highlighted 3 because they were all using the same type of modality. But certainly within Europe, we have a range of different optical interventions. And I know this varies depending on which part of the world you're in and what's available in your own part of the world. But these are out of Europe. They are CE marked for myopia management. And you can see they have all different levels of supporting evidence. They've all got different strengths to their study design as well, and a number of limitations. None of them are perfect because it's very difficult to run a perfect study. We're talking about children and young children, compliance and everything that goes alongside that. But have a little look at the evidence behind it. Have a little look at the strengths and limitations for those different studies. And you can do that just by looking at kind of the abstract in the first instance, taking into the account the key points that we have discussed today. To date, there's been no head-to-head or direct comparisons between these different interventions. So it's really difficult to compare efficacy directly from one to another. And the reasons why we can't look at percentage efficacy in one group compared to another is because, they've been done on, slightly different age ranges of children in different populations, differences in terms of compliance, etc. So that's a difficult one to manage. But certainly for any successful myopia management practice, we need more than just one intervention to offer. And there will be cases where lifestyle of that child may preclude one option, for example, and you may choose another. In other cases, the level of myopia may be such that that sways the choice. And within my own myopia management clinical practice, I use a range of these interventions. In fact, I use all that I have access to. But I always start from that position of, what is the strength of the evidence behind an intervention? And then what's most suitable for that individual child based on their own measures, their parameters, the level of myopia, for example. And importantly, what their preferences might be. So in some way, I really want you to consider when you're looking at information out there, especially if it's a new intervention that's come on board and you haven't yet been to a conference to hear about it, you could just read that abstract from that peer-reviewed publication. You can tease out those key points just from that abstract. So we're looking to see, what type of study the paper describes, what's the quality of the research. Can you tease that out from the abstract? And importantly, are those study findings relevant to your own patient population that you see in your clinical practice? I think if you can address some of those points by looking at the abstract, and then if you're convinced from reading that abstract, then go ahead, delve deeper into some of those other parameters that we discussed previously, and look at that whole paper in more depth. So relating back to kind of our pyramid of hierarchy of evidence, we're looking for that randomized control trial, which sits right near the top of our evidence base. And I think for many optometrists, eye care practitioners will, listen to talks and things, and then they'll still ask me, but which intervention should I choose? Where should I start from? And the first place to start is one, great that you're on board with wanting to intervene, slow down myopia progression in children. And two, what have you got available in your own clinical practice? Because that will also influence what you're going to do. And then we're looking at that research evidence that you have to support the use of that intervention. I typically use an optical intervention as the first choice, and that's because these children are myopic. They still need a correction. So if I'm giving them correction and I've got an option for myopia management in an optical form, then I'm going to use that. We need to think about what's going to give good compliance. Is it a child who's got the glasses on, off all the time? They're not necessarily going to get the best effects through a spectacle lens option. You might think about a contact lens. If it's a child that swims several times a week, you're not going to put them in a soft contact lens, and you might think about ortho-K. So lifestyle really plays a large role in terms of deciding what intervention. Ease of fitting, and pretty much, lots of these are straight forward to do. But I think it's really important that we kind of review our choices. We need to keep up to date because these will be changing over time. And importantly, share that with the child and the parent. What happens, what I tell them today when I see them in practice and what I tell them in the next visit, it might be something different because new evidence has come on board. In terms of atropine, I work in the UK and we don't, it's not licensed for myopia management. We don't really have access to it as optometrists. But certainly there's still a question there in terms of that strength of the evidence, certainly for very low doses of atropine, in terms of how well it impacts on slowing axial length growth. We know it works on managing myopia progression, but for the 0.01%, it's less clear cut what it does in terms of axial elongation. One useful resource that you might want to look at is the International Myopia Institute. And this is just an international group of academics, researchers, clinicians, representatives from industry. And they've produced a series of white papers, and those white papers have all been published. They're all open access, and it's in the journal Investigative Ophthalmology and Visual Science. They're also available via the IMI website. And these papers cover a range of topics such as the definitions of myopia, the different interventions, guidelines for clinical trials, and there's one on clinical guidelines that you might find really useful. The first series of papers was published back in 2019, and there's just been a second series of papers published this year. So as I said, they're all open access, available via the IMI website or the IOVS journal website. And they also have an annual digest to keep you updated. Another aspect you might want to consider is your professional body guidance. And of course, this will vary by country. Certainly in the UK, the College of Optometrists are a professional body, and their guidance is out of date and really needs to be updated. So, make sure that push for your own professional body to keep up to date as well. Are the interventions you're using had regulatory approval for use in your country as well? And what I'm really pleased to see is that the World Council of Optometry are clearly on board with aspects of myopia management. And you can see here the World Council of Optometry resolution on the standard of care for myopia management. 3 things to consider, and that's mitigation, measurement, and management of myopia. So I hope you're all on board, and I'm hoping that this is giving you some insight into saying, yes, I'm in practice, I'm in clinical practice, but I can be on board with knowing the latest evidence, assessing that quality of evidence for myopia management. So thank you very much for listening to me this evening. I'm going to stop sharing my slides with you now.
Thank you, Dr. Logan. That was fantastic information. Personally, on a personal level, I find weeding through the evidence for myopia management, it's an never-ending process, because this is a new and emerging field that we have, and it's hard to keep up, let alone for us as practitioners, but for us to be the conduit for our patients to try to keep them informed on it. So thank you for helping us be better discerners of the clinical evidence. We're just looking to see if there's any questions, and I don't think there was any questions at this time. But again, thank you so much for your time. And for all of those you listening, if you want to hear more about myopia management, tune into our next section, because we're going to be talking about common ortho-K mistakes that you might be making in your myopia management. So I look forward to seeing you in a couple of minutes.